So my name is Elijah Painstsil, and I'm a professor of pediatric infectious diseases, pharmacology, public health, and management at Yale School of Medicine. And I happen to be the section chief of pediatric infectious diseases at Yale as well. And as was said, I happen to come from Ghana. So. Good. So I think this is going to be a very short conversation about measles, and I think we are discussing because of what we are hearing. And I think it would probably go into the questions section, and then we would really fresh things out. So next. So this is what I want to leave with you. So we've been able in the United States for the last decade. These bars are showing you how many cases of measles, the whole US, 50 states, how many we get. And usually it's been like under 100 until 2014 that we shot up to 667. And most of these cases had been what we call cases that had come from other countries. Students who have gone elsewhere and have brought it. And usually they bring it to where people have not been immunized. Unfortunately, if you look at the 2019, we are only in April and we're already having 465. So when a community has more than 3 cases of measles, we say that you have an outbreak. So that's why you're hearing about that. We have it in New York, a couple of states, and in Connecticut, we just diagnosed our first cases last week. So it's now becoming a problem, and we would see why it's a problem next. So these are the states that have it. So if you're planning to travel, choose your places safely. Don't go to New York, which I did this morning. So there's a little bit about history of measles so that we put it in perspective, and it will become clear why I like this history. So that we remind ourselves and we just don't forget where we have come from and just don't let things go. So that's been diagnosed. We have gotten to know about it very, very early in life, and people have worked. I mean, as far as 1757, people were working at it to help us today. And we in the U.S. it became a communicable disease and notifiable. So that if somebody has measles, you have to let the health department know in 1912. And for the first 2 decades, we were averaging like 6,000 cases a year. And as I showed you, now we are in the hundreds, only that this year it's not ended yet, but we have high cases. So from 1963, we got a vaccine that had been used. And as was said earlier, even though the vaccine is not 100% protective, it's able to reduce by about 80% of the cases, because we were getting this 6,000 a year, and now we are in the hundreds. So it was better. And you would also appreciate that, as with HIV, Ebola, the measles may not kill you. It's other infections that you get when you have measles, because measles is able to downgrade your immune system. Next. So a group of scientists decided to really work on a vaccine. In 1963, they isolated the virus from, there was an outbreak in the Boston area, and they isolated a virus from one of the children that had that outbreak. And because now they have the virus, they were able to study, and they were able to really change the potency of the virus so that they could make it in the vaccine. So the measles vaccine, unlike most vaccines, it's a live vaccine. You get the virus itself. but it's very low in terms of causing infection. It will not give you the big infection. Next. So one thing that we pride ourselves actually, maybe Harvard has to take credit of that, but we do in New Haven here as well. My boss, my mentor, actually worked in the lab of John Anders, who helped us to get a first measles vaccine. So our labs study a lot of measles as well. So we are very familiar. And for some reason, all the viruses we are talking about today are RNA viruses. There are two types of viruses, DNA and RNA. And measles is also one of them. Also has the same capsule, and it really fools the body to think that, oh, I'm just part of you. And that's why it becomes difficult too. Next. So this I've already shared with you the vaccine development at John Anders lab and elimination. So we have set ourselves to eliminate because we have a vaccine. Even though it's not 100%, it's able to get the job done. And the problem is with human beings. We have our own problem. There are a lot of people who will not take the measles vaccine. It's becoming a huge burden now, not only in the US, but outside of the US. Vaccine hesitancy. People are complaining that the vaccines make their kids sick, and then the vaccines that had to be given on certain dates or periods, people are now spacing them. They will say, oh, my child cannot take all two today. Oh, no, 3 is too much. Can you space that? So we are now giving these viruses the chance to re-enter our community. And if you look at this outbreak now, it's actually in communities where they do not take vaccines. Previously, it's imported. Somebody would come from Africa or would come from somewhere in Eastern Europe, and you would inoculate people. But now it's homegrown because people are not taking vaccines. Next. So this is next slide. Also, sorry. So this is briefly the transmission, and it's really very contagious. If you come into contact with a person with measles, the chances that you would be infected is 90%. So 9 out of 10 people who are exposed to measles get it. So it's really, really that high. And how do we get it? It's in airborne. People would cough, they will sneeze. And unfortunately, when you sneeze into the air, because the particles are very small, they are suspended in the air for, at least we know, for 2 hours. So that somebody could sneeze in this room and you would come in and say nobody is here. But measles would be here if the person is infected. And unfortunately, people are more infectious before even the rash appears. So 4 days before you get a rash, you are very, very infectious. And if people are not sick, not with a rash, I mean, you take them as normal. So that's why it's becoming very, very difficult to do that. Next. Signs and symptoms, again, high fevers, they have cough, the runny nose, and the eyes will be red, conjunctivitis, and it's actually in their throat, some patches, white patches that actually help us. Within the 3rd day of measles, you would see that patches in the throat, and if you have that, we can make the diagnosis. Next. So these are just pictures to show you how the rash look like. The right upper corner is showing you the throat and some of the white patches that we call complex spots there. It actually makes the patients very miserable. They have high fever, 104, 105, and they don't want to eat anything. Next. Again, we have serology blood tests, and you could either do the antibodies to the measles, or you could also really quantify the virus itself. what is done now is that with a PCR, you only have to, it's done in the state lab. So if a doctor suspects a patient has that, you take a swab from the nose and you send it to the state lab. You have to also call them before, and especially because we are having outbreak, that each hospital has a way of managing this. Next. Prevention, again, the main thing is vaccine, but these are more for the hospital because it's transmitted in the air. You would see that they have a mask on and gloves and what have you for the protection. I think next one is the last slide. It's in the category of diseases that we take airborne precaution, and you have examples. Measles and TB could be in that category. I think that this is the slide. There are a lot of information, and those online could go online to that. But I think the problem with organizations like ours is to help people to really be vaccinated. They are the problem now. If your neighbor is not vaccinated, they get it. And then if you are unfortunate and you have diabetes or some immunocompromised state, then you can be reinfected. And again, once again, thank you for inviting me and thank you for your attention.